Next, we move on to the long case presentation by Dr. Anushri and Dr. Mohammed Nabil on the topic multinodular goiter for thyroidectomy. The internal examiner for this case will be Dr. Paul or Raphel. Unfortunately, due to unforeseen circumstances, Dr. Paul will not be able to join us today. Hence, the internal examiner and the external examiner is going to be Dr. Saneesh PJ, Senior Consultant in Anesthesiology and Critical Care at Ananthapuri Hospital and Research Institute, Trivandrum.
Good morning, everybody. We'll start with the second session. I'm actually extremely happy and proud to be sitting here as one of the examiner. Actually, I'm doing the role of internal as well as external examiner. That's by chance. My memory dates back to around 2006 when during one of a similar program, I was presenting as a postgraduate. The topic was liver disease, and my examiner is right in front of me, Dr. Guridat. so it's a happy occasion. So I told my candidates also, there should be a time when you sit here as an examiner and I'll be in your audience. So in this long case discussion, we have 40 minutes time. So I'm planning to do it in a format like 25 minutes. The candidates will be interacting with the examiners without interruption. Then 5 minutes we'll have a debriefing on how they answered. Probably we can take opinion from the senior examiners also. And then we'll quickly go into the other scenarios which can come in the topic of thyroid and anesthesia. So I request the organizing team to just give me a warning when 25 minutes is over. Okay. Yes. Can you please introduce yourself quickly?
I am Dr. Nabil from Malabar Medical College, third year, JR.
Okay.
I am Dr. Anusri, Malabar Medical College, final year PG.
Okay. So both candidates are audible. Let's start. Okay, you can start with the presentation.
Good morning to all. So, history, 30-year-old female from Calicut who is a housewife with the chief complaints of swelling in front of neck since 2 years. History of presenting illness, she was apparently well 2 years back. Later she noticed swelling in front of neck. It was insidious in onset, initially noted on the right side of neck and gradually increased and extended to the left side of neck. And there is history of loss of appetite, heat intolerance, tiredness, tremors were experienced in the first year and now it is absent. And there is no history of change in voice, no history of breathing difficulty, and there is no history of difficulty in taking solids and liquids, and which is not associated with pain.
Dr. Nabil, what is your intention behind asking these targeted questions like loss of appetite, heat intolerance, tiredness?
Actually, I want to know whether the patient is hyperthyroid or hypothyroid. So, from the history, I found that there is loss of appetite, heat intolerance, tiredness, tremors were most prone to hyperthyroid features.
Okay. They were indicating towards a hyperthyroid
features.
patient. But again, you are mentioning that it got controlled after some time, maybe due to medications.
Actually, I'm on the slide, sir. So
Okay.
medication.
So how about the duration of swelling?
Actually, she had swelling since 1 year. It was insidious in onset and gradually it progresses to a size and which is not associated with pain and which is moving with deglutition up and down.
Okay, fine.
And there is no history of palpitation, no history of sleep disturbances, no lethargy, cold intolerance, weight gain, and constipation. And there is no history of irregular menstruation, diarrhea, and no history of dry skin, loss of hair, and easy fatigability. Past history.
Dr. Anushree, can you just elaborate the symptomatology of a hyperthyroid patient system-wise?
General symptoms include malaise, heat intolerance, sweating, and central nervous system symptoms include tremor, palpitation, anxiety, nervousness. Cardiovascular symptoms include angina, breathlessness, palpitation, and in genitourinary there will be menorrhagia and loss of libido, and there will be eye signs. X ophthalmos are the major, more common.
Okay, eye signs. So
Eye
how about
signs.
this thing, hypothyroid features?
Hypothyroid patient will present with cold intolerance and arthralgia, myalgia, and then a patient present with CNS symptoms include there will be bradycardia, angina.
CNS?
CNS. The patient present with CNS symptoms include patient present with muscle wasting, lethargy, malaise, and cardiovascular symptoms include bradycardia, then features of decreased cardiac output, and genitourinary there will be loss of libido and oligomenorrhea. And eye signs are, there will be no eye signs in hypothyroid patient.
Okay. So how do you distinguish between, say, primary thyrotoxicosis and secondary thyrotoxicosis?
Okay, primary thyrotoxicosis is mainly due to increased production of thyroid hormones. That is, the pathology is mainly in the thyroid gland itself. In the biochemistry, we can see there is increased TSH and increased T3 and T4. The secondary hyperthyroidism is mainly due to dysfunctions outside the gland due to excessive stimulation of TSH, that is thyroid stimulating hormone. That is, we can see in gestational thyrotoxicosis and TSH secreting pituitary adenomas. And in primary thyrotoxicosis, the CNS manifestations are more common. In secondary, the CVS manifestations are more common. And in the primary, obstructive symptoms are less. In secondary, the obstructive features are more common. And the specific treatment for the primary thyrotoxicosis is mainly antithyroid drugs and radioactive iodine therapy. In secondary thyrotoxicosis, due to obstructive features, we have to go for the surgery.
Okay. Proceed with your past history.
Okay, past history, there is no history of coronary artery disease and cerebrovascular accidents, hypertension and diabetes. There is no previous history of surgery and hospital admission, and no history of radiation exposure to the patient. Family history, there is no similar illness in the family. Drug history, she is taking carbamazole 20 mg for the past 6 months, and socioeconomic status, she belongs to a lower middle class family. Personal history, she is taking mixed diet, sleep and appetite normal, normal bowel and bladder habits, no addictions, and regular menstrual cycle.
Okay.
I will be continuing with general examination. She is moderately built and nourished, height 160 centimeter, weight 50 kg, BMI 19.5 kg per meter square, with normal facials, no eye signs, skin, hair normal, no tongue or hand tremors. Next. No pallor, no icterus, cyanosis, clipping, lymphadenopathy or edema. Vitals, she is febrile, pulse rate is 88 beats per minute, regular rhythm, normal volume and character, no radiofemoral delay, all peripheral pulses bilaterally felt equal. Blood pressure 120 by 70 millimeter of mercury in right arm in sitting position. Respiratory rate is 16 per minute, regular and thoraco-abdominal pattern. Coming to airway and spine assessment, no gross facial dysmorphism, bilateral nasal passage is normal, mouth opening more than 3 fingers. Mallampati classification class 2, thyrometer distance couldn't be measured, sternometer distance is 13.5 centimeter, neck movements normal, no tongue normal, no loose tooth or dentures. Temporomandibular joint, no ankylosis, 1 finger insinuated, upper lip bitus, grade 2, no retrognathia, submandibular space normal and spine normal. Coming to local examination, First inspection, a large swelling of size about 8 into 5 centimeter present in the anterior aspect of neck, which extend vertically from lower part of thyroid cartilage to 1 centimeter above the suprasternal notch. And horizontally it extends from anterior portal of sternocleidomastoid on either side, and the swelling moves with deglutition. Skin of the swelling is normal with no dilated veins or scars, no visible pulsation and no other swelling in the neck. Palpation, no local rise of temperature or tenderness. A swelling of size 8 into 5 centimeter present in the anterior aspect of neck. Swelling is firm in consistency with nodular surface, multiple nodules palpable, largest nodule of the right lobe which moves up and down with deglutition, extending vertically from lower part of thyroid cartilage to 1 centimeter above the suprasternal notch, and horizontally extend from the anterior port of sternocleidomastoid on either side and is not fixed to skin. Carotid artery pulsation palpable, not displaced, no bruit, Koch's test negative and Pemberton test negative.
Can you explain the Koch's test part?
Actually, the Koch's test is positive. If we push the lateral lobes of the thyroid, the patient may experience stridor. And Pemberton test, we ask the patient to elevate the both hands above the head. The patient may experience facial congestion and respiratory distress due to stridor and congestion over the neck.
So what does it indicate?
It indicates...
It explains that there is a thyroid swelling causing thoracic inlet obstruction.
Okay. So in this case, it's not there.
Sir.
So clinically also, palpation also, there is no indication about any retrosternal extension.
Percussion, resonant not over the manubrium sternum, auscultation, no thyroid bruit. Summarizing, systemic examination, cardiovascular system, precordium appears normal, no dilator veins or scars, apex beat felt at 5th intercostal line, 1
Okay,
centimeter.
any positive findings?
No, sir. Systemic
Fine.
examination within normal limits. Coming to summary, 30-year-old female with large thyroid swelling in front of neck for 2 years without any pressure symptoms, with normal thyroid function, without any toxic features and without comorbidities. On examination, swelling in the anterior part of neck, which is 8 into 5 centimeter in size, firm in consistency with nodular surface, with multiple nodules, moves up and down with deglutition, extending vertically from lower part of thyroid to 1 centimeter above the suprasternal notch and horizontally extend to the anterior borders to sternocleidomastoid. Provisional diagnosis, multinodular goiter with euthyroid status.
Okay, as of now, we know that there is a swelling, thyroid swelling, most probably
Yes,
it's a thyroid swelling. And imagine that this case is posted for tomorrow for thyroidectomy. Okay, so in summary, I would say it's 30-year-old female with a thyroid swelling, no retrosternal extension, no compressive symptoms on the trachea as well as the esophagus, and no indication about any retrosternal extension. So you know this patient. Now how do you want to evaluate?
So
how do you
I
progress with the workup of this patient for an elective case?
I would like to do a complete blood count to know the baseline hemoglobin level, and also I will look total WBC count to rule out any infection, and my patient is on carbimazole and it may cause agranulocytosis, so I will check for any neutropenia. And also I will do thyroid function test. In hypothyroid patient there will be low TSH with raised level of FT3 and FT4 values, and also I would like to do renal function test and a random blood sugar test, because hypothyroid patient might present with glucose intolerance. And also I will do a serology to look for antibodies against hepatitis C virus, hepatitis B and HIV. And I will do a blood grouping and cross matching to reserve blood for surgery, and ECG to rule out, to know the baseline ECG and to know is there any tachyarrhythmias. And coming to the radio imaging techniques, I will do X-ray neck with X-ray chest with neck to know AP and lateral to know the tracheal deviation and compression. And if the compression is more than 50%, I would like to do CT thorax with neck to know the extent and the tracheal invagination and to the surrounding invagination of thyroid gland to the nearby structures and the narrow tracheal diameter, and so that I can prefer a correct size ET tube during intubation. And I would like to do, I would give a ENT surgeon consultation to assess the vocal cord, and I will do pulmonary function test and flow volume loop if there is
As of now, is there any indication about
No,
any
sir.
vocal cord issue? No.
No.
This is just a baseline investigation.
Investigation.
So indirect laryngoscopy they can do and study the vocal cord movements. Okay, any other method other than an ENT consultation, getting an indirect laryngoscopy done? You can as well do a fiberscope also, because
sir.
most of the OPDs now are facilitated with a fiberscope. So under topical anesthesia they can check the vocal cord functions
Prior to the surgery.
preoperatively. Okay, fine. So case is posted for tomorrow. The investigations say thyroid function, biochemically also patient is euthyroid. Hemoglobin is acceptable limit, say 12 gram percentage, no total count raise. You mentioned about renal function test, electrolytes are normal, ECG is normal. So how do you want to prepare the patient?
Okay.
Day before surgery, what all instructions you need to give, or what all things you need to check just the day before surgery?
On the day before surgery, I will meet the patient and I will reassure the patient, because most of the patients were anxious due to the surgical procedure that is taking tomorrow. So I will reassure the patient, and I will reduce the anxiety, and I will make her more comfortable, making a good rapport between me and her. Next, I will roughly go through the PAC paper to know whether she is taking any drug. For my patient, she is for carbimazole. So I advised her to take carbimazole tomorrow also with sips of water. And I will advise her regarding the NPO status. As my case is posted on 8 a.m. tomorrow, so she had to be NPO for salt food from 12 a.m. and clear liquids from 2 a.m. And I will ask her to...
Clear liquids from?
What, sir?
Clear liquids from?
6 a.m. sir.
6 a.m.
6 a.m.
Okay.
2 hours.
2 hours prior. Okay.
And I will give anti-anxiety agents like tab alprazolam, that is 0.25 mg, that is prior to sleep. And I will ask for any symptoms for upper respiratory tract or lower respiratory infection. And I will check the vitals of the patient, that is blood pressure, then pulse, then room air saturation, then pulse rate and BP. And also I will counsel the procedure, what is going to be done tomorrow, that is general anesthesia to the patient to make her more comfortable. And I will counsel the bystanders also regarding the procedure and complications.
Okay, Anushree, what you will tell the patient regarding the anesthesia, what she needs to anticipate?
I will tell the patient that don't to be get worried. You will have a good sleep. After the sleep, we will be will not aware of the surgery, and after the sleep, we will get a nice sleep, and after awake from the sleep, you will be in the post-operative room.
Okay, so basically you will not be giving too much technical details to the patient. So once the patient is wheeled in, she will get some injections, then she will have a comfortable sleep. When she wakes up, surgery is over, but she will be in an ICU. She will be shifted to an ICU till she is perfectly fine, ready to be shifted to room. Okay, fine. On the day of surgery, what all preparations you will do in your operating room?
I will maintain an ambient temperature in the operation theatre, and I will check anesthesia machine, monitors and equipment is ready. I will arrange the intubating trolley with different size of mask and endotracheal tube, reinforced endotracheal tube of different sizes.
So what do you plan to use in your plan A? Which endotracheal tube you plan to use?
7.5 mm internal diameter reinforced endotracheal tube is planned to be.
That is your plan A. But
yes,
you will
sir.
be ready with the
Smaller size endotracheal tube.
Okay.
So, and I also will arrange with a laryngoscopic blade 2 size, 3 and 4, and also make difficult intubation trolley get ready with intubating LMA and video laryngoscope, McCoy blade, and gum elastic bougie and stillets. And also I will load drugs, pre-medication drug, opioids, induction drugs, and muscle relaxant, vecuronium. And I will, in anticipating the thyroid intraoperative complication, I will arrange propranolol, esmolol,
How do you keep propranolol ready?
Sorry, sir?
Which beta blocker you want to keep ready?
Propranolol.
IV
Esmolol also can be kept ready, sir.
Esmolol.
Esmolol.
Okay. Yeah. Other option is
Other option
metoprolol.
is beta.
Metoprolol. IV
Metoprolol.
option. Okay.
And antithyroid drugs including propylthiouracil, and carbamazole. My patient is on carbamazole. I would like to prefer carbamazole. And
These
I
are
will get,
oral drugs, right?
yes, sir.
So
And
how do you
along
plan
with
to
the-
administer in case of
through
necessary?
RT tube, Riles tube.
Trials tube. Okay, fine.
And also I will keep ready with hydrocortisone and the dexamethasone. And I will also check emergency drugs including atropine and adrenaline is kept ready. And I will check suction suction is working, and also make ensure that OT table is working properly. And also will arrange infusion syringe pump for starting infusion, and also will arrange DVT pump.
Okay, would you like to
And
keep
also-
anything
and
for
also I
our
will-
IV infusion pumps? You mentioned, is it for esmolol?
Actually, sir, we are planning to give dexmedetomidine infusion to the patient.
For the intraoperative?
Intraoperative.
Okay, fine.
And also I will keep settings for eye protection in this patient.
Fine, fine. So on the day of surgery, your patient is in the preoperative holding area. You have checked the machine, you have kept the OT ready. Now you are wheeling in the patient. So you can proceed from there.
Okay, sir. I will shift the patient to the OT and I will put a wide bore cannula of 18 gauge and I will start fluids, commonly RL, that is ringer lactate, at a rate of 100 ml per hour. And I will attach the pre-induction monitors, that is blood pressure, pulse oximetry, ECG, and I will start pre-medication the patient with injection midazolam 1 mg and opioid fentanyl injection 100 mcg IV. After that, I will pre-oxygenate the patient for 3 minutes and I will slowly induce the patient with propofol, that is titrated dose of propofol can be given to the patient. Once the patient become apneic, I will start bag and mask ventilation. If I can able to ventilate the patient, I will proceed with skeletal muscle relaxant, that is here I am using injection vecuronium 5 mg and I will ventilate the patient for 3 minutes. 90 seconds before intubation, I will give injection esmolol to blunt the laryngoscopic response. Then after that, I will put a flexometallic tube of size 7 mm and I will fix the tube carefully because due to positioning of the patient, sometimes it may come out, that auto extubation can occur. After that, I will connect it to the ventilator, that is close to the ventilator with and maintaining the anesthesia with oxygen, air and sevoflurane. After that, I will
So what circuit you are using?
close circuit.
Closed circuit.
Closed circuit.
System. Okay.
And I will start dexmedetomidine infusion to the patient at a loading dose of 50 max per kg over 10 minutes and maintains at a dose of 10 mcg per hour.
No, I didn't get that. Dexmed dose.
Dexmed loading dose of 50 mcg.
Okay, 1 max per
One-
kg.
one
that,
max per
that is
kg.
over 10 minutes, right?
10 minutes and
Okay.
maintains at a dose of 10 mcg per hour.
Okay, fine. That's a titrated dose.
Titrated dose.
Depends on the hemodynamics and all.
Status,
Okay. Is there any role for hypotensive anesthesia in this case, or you can have some other measures to help the surgeon to reduce the blood loss? Would you like to go for a hypotensive anesthesia, or you can have some other measures like proper positioning of the OT table so that the venous drainage happens by gravity, and probably you can have antifibrinolytic agents like
Tranexamic acid can be given to the patient, sir.
Okay. So during surgery, what are your monitoring?
During surgery, I would like to monitor the heart rate, blood pressure, saturation, and then EtCO2 value, urine output, temperature, and the neuromuscular monitoring and the surgical field to assess is there any blood loss.
What is special in monitoring temperature in this patient?
It's a hyperthyroid patient, so I am anticipating a thyroid storm during surgery.
No, it's not a hypothyroid. No, you
It's
said it's
euthyroid.
clinically and biochemically euthyroid, but still you keep high index of suspicion for a possible thyroid storm because the surgeon is handling the thyroid tissue as such, can release the thyroid hormones into the circulation. So that is one thing. Anything else which can give you an indication regarding a thyroid crisis or thyroid storm?
There will be raised EtCO2 value, there will be hypertension, tachycardia, tachyarrhythmias, flushing, raised EtCO2 and the exhaustion of soda lime, and there will be hot canister, soda lime canister.
Okay. So it can simulate a hypermetabolic phase, and it can increase the CO2 output and can have all the manifestations. So suppose that happens, what is your backup plan? How do you manage a possible thyroid storm? What are your differential diagnoses first?
Actually, my differential diagnosis for this is malignant hyperpyrexia, neuroleptic malignant syndrome, then pheochromocytoma. So I will ask the surgeon to stop the procedure. I will increase the FiO2 to 100% oxygen to the patient, and I will start to cool the patient with cooling blankets, and I will keep a Riles tube and push cold saline to the patient, and I will give bladder wash to the patient with cold fluids, and I will give drugs, that is in order to decrease the hormone production, that is tablet propyl thiourazil at a dose of 200 to 400 mg through the RT tube, and I will suppress the sympathetic response by giving injection esmolol and injection propranolol to the patient, and I will also give glucocorticoids, that is hydrocortisone 100 to 200 mg or dexamethasone 2 mg to the patient.
Dexamethasone 2 mg?
No sir, 8 mg to the patient.
Okay, fine. So if your differential diagnosis stands still at malignant hyperpyrexia, what drugs did you miss?
Dantrolene sodium.
Sodium.
Have you seen dantrolene sodium?
No sir.
No, sir.
Okay, fine. So you are proceeding. The surgery, you need to assess the surgical field. Why do you need to assess the surgical field? Want to know about the blood loss?
Hemorrhage. Blood loss.
Hemostasis.
Okay. Anything else?
Then to know the, I asked the surgeon about the trachea.
Okay, if it's a huge thyroid swelling, surgeon's palpation of the trachea will give you some input regarding the tracheal
Tracheomalacia.
wall strength also. Okay. So now the surgery is over, your vitals are fine. So how do you plan to extubate? Because now most of the institutions, I think surgeons might demand he wants to have a check on the vocal cords movements as. So how do you plan your extubation?
So before extubation, I will talk with the surgeon and to know the integrity of the trachea. If they are suspecting tracheomalacia, I will do a cuff leak test, and if there is absence of cuff leak test, I will indicate the tracheomalacia, and then I will electively ventilate the patient for 48 hours and give a trial of
Before that,
extubation. And
which
if there
phase
is
you can do the cuff leak test? Because you have to reverse the neuromuscular blockade. Then only you can expect the patient to breathe on patient sound, no? Or you can do it before that also.
before extubating, giving a thorough oral suction, deflate the cuff and see the difference between the set tidal
No,
volume
what I want to know is, are you doing it after reversal of neuromuscular blockade, or even before that you can try this?
even before neuromuscular blockade.
No, sir, actually when the patient is coming out of the neuromuscular blocking agent, we can do a cuff leak test.
Okay. So why this trachea didn't collapse before the surgery? Because the
Because-
swelling was there for some time. You said 2 years plus.
Because of the stretching of the pretracheal fascia, it will make the trachea make the tracheal patency, and after the removal of the trachea, means thyroid gland, it collapses because of the pretracheal fascia, which tenses the pretracheal fascia is removed after the surgery.
Okay. Most of the infraglottic swellings, the collapse occurs usually when there is a negative pressure breathing. Patient switches back to negative pressure breathing, there is more chance of this tracheal wall collapse. So maybe once the patient goes into a spontaneous breathing, your evaluation is going to be more meaningful, because eventually we want to know whether it collapses during that phase. Once we switch over from positive pressure breath to negative pressure breathing. Okay, fine. So apart from cuff leak test, anything else you can do? I said about checking the vocal cord mobility.
Vocal cord.
So how do you plan to facilitate that?
So with the help of a video laryngoscope, I will see the vocal cord with the help of a low dose
That is after
propofol.
extubation.
After extubation with a low dose propofol or with the continuing dexmedetomidine infusion, I will see the vocal cord movement with the help of a video laryngoscope. The advantage of using a video laryngoscope is that I can record the vocal cord movement, and at a time multiple individual can visualize the vocal cord movement.
Okay, that's a kind of documentation.
Medico-legal documentation.
Okay, and most of the time this paucity of movement is going to be transient also because of the surgical handling or edema. It could be transient also, but for that documentation at that particular point of time, yes, that is one method. Okay, so after you pull out the tracheal tube, endotracheal tube, the patient is breathing spontaneously. So what are your concerns before shifting the patient to a post-anesthesia care unit, and what do you monitor in the post-anesthesia care unit? Your analgesia plan or your post-operative instructions?
Actually, sir, before extubation, we will give the patient superficial cervical plexus block for proper analgesia.
Good.
And after extubation, I will monitor the patient if she is taking regular breath with the adequate tidal volume and she is obeying the commands also. After that, I will shift the patient to the post-operative surgical care unit, and I will attach the monitors, that is blood pressure, saturation probe, ECG, and the temperature monitoring is also very important. So I will keep the temperature probe, and I will also monitor the urine output of the patient, and I will and keep the patient NPO for 6 hours, and I will start IV fluids, that is ringer lactate or normal saline at a rate of 100 ml per hour, and I will keep a face mask of oxygen of 5 liters per minute, and I will also give analgesics like paracetamol to the patient, that is 1 gram 8 early, and I will inform the staff nurse to monitor the patient for any collection of drainage and any hemodynamic disability occur during after extubation, after extubating the patient for several hours, and I will look for any respiratory distress to the patient, and
also we'll keep a suture cutting needle near the bed of the patient.
Okay, so the hematoma formation and hematoma compressing on the tracheal airway structures is important to us. Any airway edema causing new stridor, vocal cord palsies are important to us. So which kind of vocal cord palsy you will be more worried about?
Bilateral partial adductor palsy.
Why?
Abductor palsy, bilateral partial abductor palsy.
Okay.
Because unopposed glottic closure can occur. It's a surgical, it's an emergency procedure. We have to re-intubate the patient with smaller AT tubes.
Okay. So in case of tracheomalacia, what's your plan? Suppose your leak test indicates there is tracheomalacia.
Electively ventilate the patient for 48 hours and we'll give a trial of extubation.
Maybe after 24-48 hours again re-evaluate and then have a multidisciplinary decision, because you need to get surgeons also involved, because suppose in case we require to go in for an extensive longer duration like a tracheostomy, that decision also should come from a multidisciplinary team meeting. It's 25 minutes over? Yeah, okay, fine. So, so we had a discussion of a sort of a straightforward case of a hyperthyroid case without much airway problem. So they could negotiate easily with the airway management. So without any hyperthyroid features, so we need not go into the optimization plan. I think many of the points they have come up with are nice, because they showed an intent of how an anesthesia team plans for a case preoperatively, and while the patient is in the pre-induction room, how they prepare the theatre. So this is very important. Exam also, like only the superficial cervical plexus block they skip, because the examiner didn't give them an opportunity to speak out fluently how they plan for extubation, because I straight away asked how you evaluate for the tracheomalacia and all. Probably otherwise they would have told that. So exam, whenever candidates moves timeline up and down, that means their planning is not good. But this is one positive I would like to highlight, because they have been nicely planned for their anesthesia management. But for other cases, for the benefit of the PGs, I would like to mention a few things. Like in the history, whenever you keep on telling negative points, you should have a justification. You can't say so many negatives and then if examiner asks what is the context, you don't have a clue, then you are in a bad light. So they mentioned about history of palpitation, sweating, tremors, all these things. Probably, as we mentioned, it could be classified as symptoms of hyperthyroid. symptoms of hyperthyroid, yes, negative history does matter. Looking for hyperthyroid, that also is perfectly acceptable. Whatever they say, like even when you say no family history, you should have an idea. In case examiner asks you about when is family history important in this case. If you are discussing about say hypertension, diabetes, yes. But in a trauma case, you can't say no family history. Okay. Then airway examination was fine. Okay, airway examination finding they have mentioned nicely. But again, history wise also they have mentioned no history suggestive of stridor, dysphagia and all. That is fine. Right from history that intent was there. Yes. Other thing I noted was like generally examiners will ask you how do you want to evaluate this case. Okay, evaluation generally people go into a list of examinations. So I think they have mentioned in a classified manner, like what all blood tests you need, what all imageological tests you need, what all cardiology tests you need, or specialty consultation optimization you need. So that's a good way of approaching, because that's what we do in our routine. So exam also the candidate should behave as if we are actually planning a case for our routine case. So you mentioned about the blood tests, and I think we had discussed about urine routine. Urine routine, I think we have an article on preoperative workup in IJ in our Indian guidelines. That is a very nice article. All the candidates should read that and answer according to that. You should be justified. So for whatever it is worth, let us ask for LFT may not work. Okay. So you should be justified which all investigations you are asking for. And yes, specialty consultation, like you mentioned about laryngology or ENT consultation for vocal cords, pre-op vocal cord involvement documentation. Yes, I think some of the institutions, even anesthesia team will do that with pediatric fibroscope passed through the nasal. In our hospital, our laryngology team, whenever they post a case with vocal cord issue, they will actually come to us with that video of the pre-operative vocal cord movement, which is very important for our planning. So we should be knowing whether we'll be tackling a vocal cord issue after the case. Okay. Other thing, I think most of the recent examiners definitely ask about communication skills, like how do you communicate? Dr. Nabil nicely mentioned that I'll make the patient comfortable. Okay, it's very easily mentioned that I'll make you comfortable. Am I making you comfortable? I don't know.
Yes, sir.
Yes, sir.
So the way you explain the procedure, the anesthesia procedure, I think many of the anesthesia postgraduates will start saying, after you come, I'll put a cannula, I'll give you injection, then all the monitors connected, I'll give you propofol. Patient doesn't need to know whether you are giving propofol or etomidate. Patient just need to know whether you are making the patient sleep or not. Afterwards, whether you will pass a tube down the throat, usually patient need not know unless you are planning an awake airway intervention. There you need to tell. So that communication skill is the main, I think one of the points which we examiner will try to extract from the candidates. This is what we actually do. Say before taking the consent, we should tell the patient if it is spinal anesthesia, you will be given an injection in the back. Afterwards, you will have numbness in both lower limbs, which usually wears off in 3 hours, 4 hours like that. That information should go. Now the problem is, many of the residents might get confused about high-risk patients, whether you need to inform everything to the patient or bystander. To me, I think whenever you speak to the bystanders, you can speak in a different tone about the risk, mortality, stroke, everything. But to the patient, especially in a hyperthyroid, possible hyperthyroid patient, you want to keep the patient non-anxious. I think you have to be more judicious in it. Sir, any input, sir? Because it's a difficult question. Can you pass on a mic?
Very well discussed, Dr. Saneesh. Everything was fine. Only thing was history was very confusing. So some of the features they were telling about positive for hyperthyroidism, and we were thinking that it is an hyperthyroid case. So that is one thing they'll have to, because you
No,
know,
they mentioned it's controlled afterwards, after treating antithyroid drugs.
uh-huh. So another thing is, you know, some of the examiners are fond of asking about eye signs, even though it may be a secondary hyperthyroidism and no graves ophthalmopathy is there or not. So I have seen many of the examiners are very fond of asking about all the eye signs, dark impulse sign and then Jeffries,
Stelvax.
Mebius, Stelvax, all those things. So that you should always remember.
Okay, sir.
And during again intubation, in order to, you are telling about you have to be careful so that you know patient may have an auto extubation and all. So some of the examiners want you to tell deliberate endobronchial intubation you do, and gradually keep auscultating and then bring the or withdraw the endotracheal tube such that it is just above the carotid. So that when they put the patient into head extended, neck extended position, so the tube will still be in the middle of the trachea. So that is another important thing you can always add.
Thank you, sir.
I think thyroid is a very interesting surgical topic, right? So whatever methods you have learned during your UG time, Nafziger's method, Pisillow's methods, Cocker's methods, everything you need to know from clinical surgical methods. I think you have learned, right? So how do you palpate for a single nodule? How do you elaborate, elicit the stridor with a pressure on the trachea? All these things might be asked. Okay. So my personal suggestion is no need to provoke the examiner into it by mentioning it in your presentation. But yes, if examiner, you need to anticipate that examiner will ask for this. When you say no eye signs, definitely your bus can stop at that point and then we'll continue discussing the eye signs. Eye signs are important actually, especially if you say the patient has an exophthalmos, then along with our anesthesia management, care of the eye is also important. Okay. Care of the eye, pressure points, everything will be important. Okay, fine. So, I think thyroid we need to have get preparation for other possibilities also. The possibility of whether it goes into retrosternal, your planning differs. It can go up to the pre-op preparation for an ECMO. If it is a major mediastinum involving extension, that is there. Then hypothyroid also, most of the examiners will ask at least for some time. So you need to get ready with the hypothyroid patient. When you take up, what are your concerns? Delayed recovery, how are you going to troubleshoot? So clinical cases, it's a never-ending discussion. I would like to stop at this point. Thank you for patient listening. Thank you.
Thank you, sir.
Thank you, doctors. Now, I request Dr. Saneesh to kindly distribute the certificate of participation to Dr. Anushri and Dr. Mohammad Nabil.
Dr. Nabil.
May I now request Dr. Sudhish K to please come onto the stage to felicitate Dr. Saneesh.